Well, to introduce her, Dr. Sagarika Mukherjee is an FRCP and MRCP with CCST in diabetes and endocrinology, with special interest in thyroid and lipid disorders, visiting consultant at Columbia Asia Hospital, Kolkata, and numerous presentations in national and international diabetes and endocrinology conferences and several publications in peer-reviewed journals, treasurer of the Indian chapter RCPI, examiner MRCP Ireland, Clinical Examinations India, executive director and vice president, Remedy Clinic Study Group, Kolkata, teacher and facilitator of CCE BDM course of PHFI. Over to Sagarika for carrying on the session, and you might share your slide now.
Thank you very much, Shomo, for the kind introduction. I'm very grateful to the organizers for calling me. And I'm also very thankful to the sponsor, Novo Nordisk, has sponsored this session. I'll share my screen now. Is my screen visible?
Yes, you have to make it screen.
Try and put my video off so that I can get a better bandwidth. Right. My slides are not moving. Right. I was talking about the little bit touching upon the history of insulin, the present day where we are with insulin, and give you a little bit hints about what is stored for the future. Now, before insulin came in, the diabetes was aware, people were aware of diabetes for a long, long time ago, about 1500 BC. There's mention about diabetes in the Egyptian papyrus. There's mention about diabetes, even in the ancient Indian textbooks of medicine. But people exactly did not know what to do with the disease. And finally, the Greeks described this as diabetes mellitus, which means diabetes means to siphon out, and mellitus means honey, because the urine was smooth, because urine was sweet. And they said that is a disease where you have a sweet urine pouring out and the body gets wasted with wasting of muscles, and slowly the patient succumb to death. And there were a lot of interest in mankind about diabetes. Not many people used to get affected, but those who used to get affected, they usually within a few years of diagnosis because of lack of understanding of the problem as well as the lack of treatment. And researches about diabetes continued. And then finally, we had insulin in 1921, the discovery of insulin, and then things really progressed quite rapidly since then as we stand off now. Around 19th century, Claude Bernard had first described that there is something called pancreas within the abdomen, which has some insulinogenic action, and it might be that organ which is really playing an important role in this disease concerned with sugar. And then Oskar Minkowski recognized that diabetes is really coming from the pancreas. Lots of research is carried on. And then finally, Banting and Best, along with Collip, who was the biochemist, I'm sure all of you know about this history, got on to progress the research further, and then they developed the insulin, the precursor of insulin, what we have now. Now, before the discovery of insulin, diabetes was really, really fatal, and the most effective treatment for diabetes was really to put the patient through very strict dietary restriction with minimum carbohydrate intake. Starvation was one form of treatment for diabetes, and with the progress of these scientists, that is MacLeod, Collip, Banting and Best, that we have got the present day insulin. And insulin was available in very crude form. Nevertheless, it really transformed the life of diabetic patients. So if you look at this chart about life expectancies 1940s, before the discovery of insulin, the average death after diagnosis of diabetes was something around 8 years, but after the development of insulin, the average age of death from diabetes really progressed, and then we came to know about the death from diabetes really not because of the glycemic problem, but because of the complications which came on. Many of the users of insulin did die of hypoglycemia, but still insulin was a remarkable cure. And by 1940s, when insulin was used very quite rapidly for diabetes treatment, not a lot of complications from diabetes started coming in, and then people started realizing that there are endpoint complications like eye problems, renal problems, neuro problems, cardiovascular problems, which really happens because of long-standing diabetes. Now, when insulin was discovered in 1921, and after that Bunting and Best had actually sold the copyright of insulin to Toronto University just for $1. Now, Eli Lilly got in tie-up with Toronto University and started manufacturing insulin, and this insulin was U10, and it used to be injected deep intramuscular in a volume of 3 to 5 ml, and often it was seen that patient died of infection because of injection site abscess, etc. In fact, the first patient who got injection, Leonard Thompson, he survived for about 13 years after injection of insulin was started. So 1922, he survived for about 1935. And in fact, he died of pneumonia. He did not die of diabetes. He died of pneumonia. And in 1935, there were no antibiotics around because discovery of antibiotics is taking place 1941-42 when penicillin was discovered. So Leonard Thompson, the first patient with insulin, really died of pneumonia. Since then, the development of insulin has progressed quite a lot. Initially, we had animal insulin, which used to be treat humans, and then we had analog with DNA recombinant DNA technology, which allowed large-scale production of synthetic human insulin, which started coming into the market since 1980s, and there has been further developments on human insulin. So if you touch upon these figures that about the development of insulin, first insulin got crystallized, and then protamine zinc was added to insulin to make it long acting. Lente insulin came in the early 50s. And then in early 50s also we had the isofen insulin. Further developments carried on, recombinant human insulin came in, and then we had the analog insulin by Eli Lilly in mid 90s, which was the development got further with Novo Nordisk. We had aspart insulin 1999, and the long-acting insulin Glargine came into the market. Long-acting analog insulin came around 2000, and this was followed on by insulin degludec. So if you look at the research and developments of insulin, we have got now the modern insulin, which has got the basal insulin or the ultra long acting basal insulin. We have got the prandial insulin, which takes care of the mealtime and which is more soluble insulin, and which has further developed into ultra long acting insulin. And there has been talks and research is going on for development of oral insulin, which will be even faster acting insulin, and which will have the insulin directly being poured into the portal circulation, which will have a more mimicry of the physiological situation where we have insulin coming in our body directly into the portal circulation rather than in the peripheral circulation, which happens with subcutaneous insulin injection. But still, there are a lot of unmet gaps in the newer insulin, and they are still trying to cope up these gaps with better PK and PD parameters. So if you look at onto the basal insulin, we first had the NPH insulin. So this had controlled the fasting hyperglycemia, but limitation was it has to be BD dosing in order to cover for 24 hours. And also there were a lot of risks of hypoglycemia. This was advanced by Glargine U100 insulin, which was the first analog basal insulin, which came in around 2000. It had a better basal cover, was covering nearly 24 hours, that is giving you a coverage between 20 to 22 hours. But however, there was no flexibility, and there was a lot of glycemic variability as well. So we required a little bit better insulin. And then Glargine U300 came in, where risks of hypoglycemia was a little bit lower, and there was a lot more flexibility, and also glycemic variability was better. And then we have the insulin degludec, which is again the ultra long acting insulin, which provides you with a better 24-hour, or which is the ultra long acting means it provides you action for more than about nearly about 36 hours, providing better control of your fasting blood sugar levels. It has got a lots of flexibility regarding insulin timing. So cardiovascular wise also it is safe, and maybe lesser dose amount is required. I'm sure you're all very much familiar with this cartoon of insulin degludec, because it gets injected. It comes as long multi-hexamers assembled. It gets injected in the subcutaneous tissue where it dissociates slowly, forming individual monomers, and this gives it a long half-life and gives a steady state of basal insulin. So when you compare insulin degludec with insulin glargine, it has got longer half-life. It also reaches a steady state within a short period of time, giving you lesser amount of glycemic variability and has got a flat action profile. Not only this, the advantage is that it causes less amount of hypoglycemia, more so with severe nocturnal hypoglycemia when compared with glargine U100. So if you consider the unmet needs of long-acting basal insulin, that is, if you require flexibility of dosing, that is, if the patient can't inject at the same time of the day because of job commitments, because of other issues, care issues, etc., degludec really fulfills or takes care of this issue, because the flexible dosing is very much flexible. Duration of action is quite long. So if you are unable to inject at the same time of the day, you know that the insulin will give you a backup of 36 hours, and therefore the timing can be adjusted accordingly. Overall hypoglycemia is a little bit lower, and also glycemic variability is also low. Not only this, after the first insulin which came onto the market was the prandial insulin, and then we had the long-acting insulin. Then people thought about that why not bring in a combination of long-acting and short-acting insulin, and this was the reason why biphasic human insulin were developed. Initially, it was available in the different ratios of 10:90, 10% of short-acting, 90% of long-acting, 20:80, 70:30, 70, or 50:50. And then people came to settle, or globally now it is the consensus that 30:70 or 50:50 insulin is available. 30% short-acting, 70% long-acting, or 50% short-acting and 50% long-acting, and it can be injected as per the need of the patient. And when we had the analog insulin coming into the market, biphasic analog insulin also came in, either aspart or lispro, and it had the long-acting component was composed of the protamine crystallite insulin analog. And now lately we have insulin degludec and insulin aspart combination, where aspart is a soluble insulin aspart, and also degludec is also the soluble in long-acting insulin, and it comes in the same syringe. So when you look at the biphasic human insulin, the advantage was it controlled both fasting and PP blood sugar. It was very convenient because you were giving twice a day insulin, but however, there was lack of flexibility. Patient did not have the convenience. You have to leave a time gap of at least 20 to 25 minutes for the human insulin to kick into action. And also there was also other problems regarding insulin, like injection site, like stacking of insulin, lipohypertrophy, etc. So biphasic analog insulin really overcome this issue. Flexibility of dosing was there, and also it provided a better steady state and lesser amount of glycemic variability. Insulin degludec and aspart combination carried this thing a little bit further on, providing more stability with lesser amount of hypoglycemia, and thereby less amount of insulin requirement and lesser amount of weight gain. And the co-formulation comes in like this. Insulin degludec is available in hexamers, and insulin aspart is also available in hexamers, and it has got degludec has slow dissociation, whereas aspart has fast dissociation and rapid dissociation, and enters into the capillary to take care of the immediate postprandial glycemia. So you start off with the BD dosing, and progressively as patient's blood sugar improves, you can also switch on to OD dosing as per the need of the patient. There are a lot of studies available for options for insulin initiation. With co-formulation versus basal insulin has been compared. Insulin glargine once a day plus minus OAD, and insulin degludec aspart plus minus OAD has been compared in an open label randomized control study, and it has been seen that they give you similarities in HbA1c reduction, fasting, and PP control over a period of about 6 months. And also basal bolus therapy has been compared with insulin degludec aspart twice daily, and this has also had comparable results. Insulin glargine U100 plus insulin aspart at meal times plus minus OAD has been compared in a randomized open label study with insulin degludec aspart plus OAD. Similar number of patients in similar glycemic status, that is age of more than 18 years, having type 2 diabetes, uncontrolled on OADs, HbA1c of 7 to 10%, and similar type of results with HbA1c reduction, fasting, and PP reduction were seen in both groups, proving that insulin degludec aspart twice daily is comparable to insulin glargine plus aspart plus OADs given as basal bolus therapy. This is just a cartoon representing the graphs representing and showing the similar reduction of HbA1c, the light blue line of degludec aspart and the dark gray lines of glargine and aspart U300, and you can see that HbA1c reduction is comparable. Hypoglycemic events were also comparable in two age groups. Also, there is equally good reduction of fasting blood sugar levels, and the added advantage was nocturnal hypoglycemia was a little bit lesser in the insulin degludec aspart BD dosings. With the evolution of insulin, we had better insulin for mealtime management. Regular human insulin was the first insulin, but there was lacks of flexibility, and also there was some postprandial rises in blood sugar level, which contributed to the complication. When the analog insulin came in, it offered better flexibility, low risk of nocturnal hypoglycemia, and also the postprandial blood sugar level were better controlled. And when we had the fast, and now we have got a fast-acting insulin aspart, which is very quick in action, especially if it starts if insulin aspart, lispro, or glulisib, you have to wait for at least 5 minutes to kick into action. But fast-acting insulin aspart starts its action very quickly, and it mimics your physiological mealtime insulin in a better way. So it gives you a better 1 hour blood sugar control. Although there is not much saying about, not many studies comparing 1 hour blood sugar control to the complications related to diabetes, but it gives you a better stability of postprandial hypoglycemia. So this is a curve really comparing the unmet needs with conventional and rapid-acting insulin. When you have got a very ultra-fast-acting insulin, it really reaches your peripheral circulation within a very short period of time, mimicking your physiological insulin secretion, and it represses the early insulin secretion defect in type 2 diabetes, which is again one of the major pathophysiological defects in type 2 diabetes, and therefore helps your postprandial blood sugar control better than rapid-acting insulin. So this table represents the analog ultra-fast-acting insulin, which is already in the market and which is still in development. We have got the faster aspart, which is developed by Novo Nordisk, which is insulin aspart by structure. But however, there is a niacinamide attached to the molecule, which gives it a little bit more stability, and also L-arginine is attached here, which gives it more solubility, and therefore it gets absorbed to the subcutaneous tissue very rapidly. Eli Lilly has got ultra rapid lispro, which has got the treprostonil molecule attached to it, which gives you a vascular and citrate attached. Citrate provides it enhanced vascular permeability, and tresprostonil provides vascular vasodilatation, and therefore insulin absorption is very quick. There is again another insulin called biochaperone lispro, which is still in development, and this again causes vasodilatation and enhances your diffusion through the subcutaneous tissue. This graph represents like how insulin aspart, fast aspart works. Nicotinamide being attached to aspart molecule improves the absorption, and L-arginine offers its stability, and therefore once injected, it mimics your physiological insulin secretion, takes care of the first phase insulin defect in type 2 diabetes, reaches the bloodstream very quickly, and takes care, better manages your postprandial hyperglycemia, especially in the first hour after your meal. Let's come to the newer developments, because still insulin injection, although I'm sure you will experience that a lot of patients shy away from insulin injection because it's an injecting device, because it's a form of an injection, and people think that when you're injecting, the therapy is really very cumbersome, your life gets jeopardized, you might have a lot of limitation. So people ask for really if there is a tablet form of insulin available, and there has been relentless research going on regarding tablet form of insulin. Prandial insulin, oral insulin has still progressed, but now there are a lot of developments going on for oral basal insulin. Oral basal insulin, it will mimic the normal physiological insulin, because once it reaches the gut, it reaches the portal vein circulation, which is more like of your own physiology. But the challenges for oral insulin are there are a lot of protein, it has to undergo proteolytic degradation, and there is restricted absorption to the intestinal mucosa, and therefore that reduces your bioavailability. When your bioavailability gets reduced, it resides in the intestine for a longer period of time, and therefore there are concerns about safety of oral insulin regarding its mitogenic effect. Not only this, because it comes in an oral form, so what type of food you're eating also influences its absorption and the bioavailability and pharmacokinetics. Novo Nordisk has got a oral insulin preparation which is still in development, now called insulin 1338. But when studied with subcutaneous U100 insulin, it was seen that it has to be given 30 to 50, around 30 minutes before food intake, which is also all right. And within, say, about 10 minutes, it reaches your circulation and stays for about, say, 1 hour to reach its peak state, and stays about 55 hours within its circulation. But the problem was that a huge dosage of this insulin has to be given in order to meet up to the U100 subcutaneous insulin, and therefore somehow or the other, disappointingly, this research got halted, and yet the search for oral basal as well as prandial insulin is still going on. There is another kind of insulin which is still in development, and we might see it in a very near future, which is the insulin which comes in a patch called the smart insulin, and this comes along with the glucose transporter inhibitor, which is conjugated with the insulin so that your hypoglycemia doesn't happen. Around 219, there is a team of bioengineers in Los Angeles, California. They developed a smart form of insulin which can be stuck as a patch, and it's in the size of like a lithium ion battery. And there is an insulin analog which is attached to a glucose transmitter, and this is called insulin. What happens, say for example, an excess amount of insulin got absorbed, then you might get hypoglycemia, but that glucose transmitter will inhibit excess amount of insulin to prevent the hypoglycemia. So this was tested in diabetic mice, and it was found that it keeps your blood sugar level in a normal range for a prolonged period of time, and the animals were protected from the side effects of hypoglycemia because of excessive insulin delivery. But however, further research is required for this in order to be studied in the humans. So in summary, we can say that there are future studies which needs to be answered for the patient to better benefit from the from insulin analog. And as Shothinadda has just a little while ago said, that insulin has been around for 100 years, and there are a lot of new molecules around, and why can't we use them judiciously? Definitely we need to use them judiciously, and to have a better control on diabetes, to have a better control on the morbidity and the mortality profile of the diabetic patients, we need to really combine, not keep the patient on insulin alone, but need to combine these novel molecules to work alongside with insulin, so that the diabetic patients reap the full benefit of these medicines, and therefore they can touch upon all of the points of the pathophysiological defects for type 2 diabetes. So we have got further researches going on in the diabetes setting for development of further new molecules, for further new insulins, which will be more effective, more user friendly, and the patient will be able to accept it without having much more side effects. The perception that insulin has always been a very complex and a complicated issue, this notion is gradually being waded away, and the patients are being more acceptable to the insulin and take up insulin as therapy. People don't think that insulin is the last molecule or last stage of diabetes, and your impending complications are going to start off with. People's ideas are changing about insulin. But however, we need to have more innovations in basal as well as bolus insulin, as well as co-formulation, which makes life more easy for safer, flexible, and more patient-friendly insulin delivery. Thank you very much for listening. I'll stop sharing my slide set now.